So I really like being first because then I can use all the time. Seriously. I also, I want to introduce one other person that almost everybody knows, but I noticed he was here. I hope he hasn't. Oh, there he is. I think everybody knows Kees Van Dam. Kees is from Greensboro Regional Center for Infectious Diseases, formerly known as Prince, formerly known as Moses Cone. But he is now going to become the PI of that clinical trials unit for the AIDS clinical trials CTU. So, Kees, just stand up. Not everybody remembers you. Okay, so what's new in antiretroviral therapy? We're really going fast. First of all, the guidelines have changed somewhat, and I'm going to just point out some of the differences in treatment guidelines. I think probably this is focused on what medicines to start, but I think what maybe the biggest change in the guidelines, and you can ask David Wall all the hard questions during the panel, is basically the guidelines say that virtually everybody who presents for HIV care should be treated when they're ready to be treated, regardless of CD4 cell count or viral load, with, I guess, one or two exceptions. And the treatments that have been recommended have not really changed very much. There's a couple of subtle changes and one larger change that's not on this slide. The one subtle change is rilpivirine is now mentioned, and I'm going to just talk about rilpivirine really quickly. The other one is, and I will talk about more, is a new single tablet combination pill, formerly known as the Quad, which is a integrase-containing single tablet regimen that has a generic, that doesn't have a generic name because it's a fixed-dose combination. I will say its trade name once. It's Stribilt. And I'll say the trade names of the fixed-dose combinations just so people know how to order them. The ISUSA, or the guidelines committee that I'm part of, it's pretty much similar to the DHHS guidelines, except for we actually acknowledge that abacavir 3TC is reasonable as a preferred alternative for first line, provided the viral load is less than 100,000. It still can be used greater than 100,000, but we consider it preferred if it's less than 100,000. You do have to have an HLA-B5701, and you should consider the impact in people that have cardiovascular disease. These are the rilpivirine data compared to efavirenz. With my shaky coffee-infused hand, I could not draw these lines over as superimposing as they are. This is the proportion of responders that are below 50 copies at 96 weeks, so almost 80%. And they're really almost exactly the same. Rilpivirine is given at a very low milligram dose of 25 milligrams. Efavirenz, I think probably everybody knows, 600 milligrams. This was a study where they could be combined with with one of three nucleoside pairs, but the most common was tenofovir and FTC. The important point here, though, is that despite this overlapping response, the reasons for the overlap are slightly different, and that's because the way the FDA thinks about response, they consider a discontinuation for any reason kind of equivalent to a virologic failure in their overall analysis. Therefore, people who discontinue for tolerability or toxicity are weighted the same as people who discontinue for virologic failure. So this is just looking at virologic responders, is in the lower two-thirds or so of these histograms. And then there are other reasons, including discontinuation and due to AE or death, and then discontinuation for other reasons. And what you can see is for efavirenz in lower viral load, the discontinuations are predominantly for either other reasons or AEs, whereas for rilpivirine, there's a hint that there are more virologic failures. That's in the green. But if you look at higher viral load, the success rate with efavirenz is actually somewhat greater, and then you just notice that the discontinuations for virologic failure are substantially greater for rilpivirine compared to efavirenz. And then, of course, it gets made up because there are more discontinuations for efavirenz due to adverse events. And David's going to talk about adverse events. Rilpivirine has some other uses that are not yet in the guidelines, in part because they're not approved uses. One is switching suppressed patients from efavirenz-based regimens. So this is, again, to say the trade is Atripla. This is Complera. This is switching in suppressed patients. This is a small study of only 50 patients, but 49 out of 49 that made it out to 48 weeks actually were suppressed when they switched. But it's important they started out suppressed. This is a larger study, a fully powered study, where people suppressed on a protease inhibitor were switched to the fixed-dose combination containing rilpivirine, compared to continuing their protease inhibitor for 6 months and then switching. And what you see here is, again, rilpivirine's in this nice yellow color. Overall, patients remained suppressed, and numerically it was slightly better for actually switching to rilpivirine. There's obviously a bunch of bias here. But the good news is it looked like people could switch if they're suppressed to this fixed-dose combination. A couple other things. There were patients that had K103N at baseline, which is, as you know, the kind of signature mutation for efavirenz. And these patients actually maintained suppression after switch. And it didn't matter how high people's baseline viral load was, they still remained suppressed after switch. But remember, they had to be suppressed to do this. They were not viremic when they switched. So what about this quad, this 4-drug combination, tenofovir, FTC, L-vitegravir, and cobicistat? Cobicistat is a ritonavir-like booster, except it has no antiviral activity. So it has no effect on HIV. However, it does boost L-vitegravir. It's been compared head-to-head with efavirenz, FTC, and tenofovir, again, as a fixed-dose combination. So this is the first comparison of fixed-dose versus fixed-dose. And kind of your very, very typical primary endpoint of less than 50 at 48 weeks using that same FDA analysis that has virologic failures and other discontinuations kind of equal in their assessment, and it's a fully powered study. A couple of things about this study. It only had about 10% women. It had also very few people of color, and that's an issue, and that would be a fine question to ask with the, afterwards during the panel if you want to know more about what could be done about that. And basically, the two therapies were very, very similar. Again, the yellow is the quadruple therapy. You can see numerically it was slightly higher, so it met non-inferiority. The other thing to notice is there's very little virologic non-suppression. Most of the, about half of the patients who aren't successful are for non-virologic reasons. So out of 300 and some patients in each arm, only 7% were not suppressed and available on study. So it's a very uncommon endpoint now, kind of virologic failure, at least in our studies. And this is a very, very similar study. I didn't show you design. This is comparing that same quad to FTC, tenofovir, FTC, and atazanavir, ritonavir, so not a fully fixed dose combination, but a boosted protease. Again, you see incredibly good success rates, 90% versus 87% at 48 weeks, obviously meeting non-inferiority, which you can see over here. And again, the virologic failures or virologic non-suppression, very, very small proportion of patients. So it's really a very uncommon event for, at least for people that get on clinical studies and take their medicine. If you look across all the various subgroups like high viral load, low viral load, high CD4, low CD4, in both these studies, it's really very, very comparable. They don't have enough data really to give you a precise estimate for women. In the comparison to efavirenz, people who were older tended to do better on the quadruple regimen, and actually people that had higher CD4 cell counts tended to do better on the quadruple regimen, and not really due to virologic failure, probably more due to tolerability reasons. The other thing that should be noted is that while there are only 5 to 7% virologic failures on these regimens, only about half of those can be actually genotyped because they're low-level failures. And so the percentage of patients that actually develop resistance is on the order of 2 or 3%. The thing to remember about the quad, I think, is that despite the fact that it's, quote, boosted, it doesn't really have a high barrier to resistance. So you see some of the known integrase resistance mutations. So 7 out of the 14 patients that had virologic failure actually developed integrase resistance. 8 had nucleoside resistance. Several had K103N. So at least 3 patients had resistance to each of the drugs. But again, it's 3 out of 350, so it's very small. And then for efavirenz, it's about the same thing that we always see. Only about half the patients have resistance mutations. And maybe due to half-life, maybe due to other things, the NNRTI mutation tends to show up first, and then the NRTI mutation. Whereas if you look in these patients, if you look sequentially, the nuc mutation tends to show up first, and then the integrase mutation. And this is pretty much the same data comparing quad to atazanavir, ritonavir. The thing that's different, of course, that's the same, different in this comparison, the same in every darn study. If you give someone a boosted protease inhibitor and they have virologic failure, they rarely develop resistance, very rarely develop resistance. So no patient out of 355 in this study who got atazanavir, ritonavir, FTC, and tenofovir developed a resistance mutation, whereas a very small number on the quad developed a resistance mutation. The other thing you have to know, and David will probably talk about this, so I'm going to mention it really fast, the cobicistat blocks secretion of creatinine. It doesn't interfere with glomerular filtration. It blocks that little extra secretion of creatinine that we all do. So creatinine levels go up by about 0.1 to 0.15 on average when you start someone on the quadruple therapy. These are some of the considerations, but I'll leave this mostly for the discussion because I think there are some interesting things to discuss. Someday, but not now, we'll actually be able to get cobicistat, the ritonavir-like booster, independent of the quad. Right now, it's stuck in the quad. You can't get it out. It's stuck in there, but maybe in a year or so, we'll be able to use cobicistat to boost protease inhibitors. This is a study where it was used to boost atazanavir and compared to ritonavir. So this is a comparison of cobicistat to ritonavir, and basically the two arms were the same. David may end up talking about whether there's a difference in lipids and other things. What will become the newest kid on the block in the next summer, probably, or maybe a little bit later than that, in early fall, is a drug called dolutegravir, which is an integrase inhibitor. It's interesting for 2 reasons. One, it's three reasons. 1 pill once a day, does not require any boosting, and it's a low milligram dose. It's only 50 milligrams. And it's been compared head-to-head with raltegravir in treatment-naive patients. And it's kind of boring, actually, because you see these same damn curves that look really the same. At 48 weeks, it was 88% with dolutegravir, 85% with raltegravir. They were very, very similar. The CD4 gain was exactly 230 in both arms. And so I guess that there's really no significant difference there. And again, dolutegravir is non-inferior to raltegravir. The virologic failures are actually slightly higher with raltegravir, and with dolutegravir, there's this interesting pattern that may or may not pan out. But so far, in none of the treatment-naive studies has integrase resistance emerged to dolutegravir. And its pharmacokinetics and its barrier to resistance in vitro would suggest that it may have a higher barrier to resistance than the other integrase inhibitors. That really has to be more fully evaluated, but the suggestions are there. And then our site participated in the single study. This was dolutegravir plus abacavir 3TC, and which will become a fixed-dose combination. It's not that yet, compared to a tripla, efavirenz, tenofovir, FTC. Large, randomized, double-blind, controlled trial. Everybody had to be B5701 negative, of course. And for the first time ever, this is slightly less boring, for the first time ever, a treatment regimen was actually superior to an efavirenz-based therapy, 88% versus 81%. The difference was entirely based on discontinuations due to adverse events or other reasons. The virologic outcome was actually very, very, very similar. It was a blinded study, so there probably was a reasonable assessment of adverse events, though many people believe they know if they're on efavirenz. I can tell you people don't know if they're on abacavir because there was twice as many HSR in the efavirenz arm than there was in the abacavir arm, in the dolutegravir arm. If you look at this, this is essentially, this bottom one here is an efficacy-related analysis. And basically, if you look at just people who, you eliminate the people who failed for non-efficacy reasons, like tolerability or loss to follow-up, you can see the two were very, very similar. And high viral load, low viral load, dolutegravir did better in the overall analysis. And it actually had a substantially better CD4 cell response. And we always see slightly less good CD4 cell responses with a triplet fixed-dose combination. And we always say things like, well, it's probably not clinically significant. I don't know, when you get into 50 or 60 cells, maybe that starts to have some impact. But I don't know. And then once again, just if you focus on this column, there were 18 virologic failures on the dolutegravir arm. 11 could be genotyped. 9 for RT, and 7 for integrase. And again, there were no resistance mutations, again, suggesting, but not proving, suggesting, again, perhaps a higher barrier to resistance. Sooner or later, we're going to have a single tablet darunavir of 800 milligrams. Probably in maybe 18 months, we will have combination pills of darunavir with cobicistat and atazanavir with cobicistat, so co-formulations of those drugs. Atazanavir will probably be a little bit ahead because the phase 3 study's been done. And then maybe later, and we're about to do this study, hopefully here, everybody cross your fingers and your toes, we're going to do a study of the first fully fixed-dose combination protease inhibitor. So darunavir, cobicistat, this is another tenofovir prodrug, and cobicistat a second time, actually FTC, not cobicistat a second time. So this is a study that I think would be quite interesting and, again, should have a high barrier to resistance. So we now have 3 single-tablet regimens. Again, we can talk about pros and cons when we get to the discussion because it's more fun. And by probably next winter, I would say, we're going to have a 4th, which is abacavir 3TC and dolutegravir. And you might say, well, why ever use more than a single tablet regimen? The boosted PIs really have this lack of resistance with failure. That's really something that you can hang your hat on. And raltegravir, while twice daily, has been superior to efavirenz over the long term in a 5-year blinded study. It has very few drug interactions. Elvitegravir is going to have drug interactions, right, because that's cobicistat stuck to it, which is a P450 inhibitor. So it's going to have many of the same drug interactions as ritonavir. So, and it, as Christopher Hurt knows, it has raltegravir-based regimens are very nice for people that need hepatitis C therapy. And finally, if you have abacavir 3TC because someone has kidney disease, there is currently no fixed-dose combination with abacavir 3TC. And then there are special populations, which we can talk about in the discussion period. HCV co-infection is a challenge. You can see that really it's only raltegravir that can be used currently with telaprevir and boceprevir, though we're exploring protease inhibitors with boceprevir. Atazanavir can be used with telaprevir, And efavirenz can also be used for tenofovir, but you have to use 50% more drug. And obviously, if someone's HBV co-infected, we try always to use tenofovir FTC. Kidney disease, we avoid tenofovir. If you have osteoporosis, perhaps you should avoid tenofovir. I think that's an open question that would be fun to talk about. And if someone's urgently need to be treated and you can't wait around for resistance data, perhaps a boosted PI is the best regimen. And transmitted drug resistance probably depends on the mutations, but I personally favor a boosted PI in that setting. And the last thing I'm going to say is nobody really knows the exact day, but sooner or later, probably within a year and a half, efavirenz will become generic. And I think that will change an awful lot in terms of how our prescription habits are dictated to us.